Welcome to today's webinar, Eggs and Sperm, What Can Go Wrong and What We Can Do to Improve Fertility. We're pleased that you joined us today. If you ask people, what's the most important thing in your life? Many of us would answer our family. But unfortunately, for some couples with problems in dealing with their eggs or their sperm, having a family is not so easy. It actually becomes a challenge that can be very difficult to overcome. I'm very, very fortunate today to be able to present alongside three colleagues who've made significant contributions to helping us to better take care of families or families who wish to have children. I'm Valerie Baker. I'm the Chief of the Division of Reproductive Endocrinology and Infertility at Stanford and also the Medical Director of our Clinical Fertility Program. I spend a lot of my time taking care of women who have a low egg supply happening at a very young age. I'm fortunate to be able to have with us here today Dr. Hsueh. He's a basic scientist and an ovarian biologist who's made many very important discoveries to helping us to better understand how the ovary works. He's also a professor at Stanford. Dr. Michael Eisenberg is one of the limited number of urologists in the United States who has a special expertise in fertility and fertility problems for men. He's made many leading research contributions and is also an active and busy clinician who cares for men with problems with their sperm. And then finally, we have Dr. Renee Reijo-Pera, who's a basic scientist and a real leader in stem cell biology. She's made very many important contributions to understanding how sperm are created, as well as done some very, very important work related to the development of embryos and eggs. And she has formerly been at Stanford and currently is assuming multiple leadership positions in Montana. The topics that we'll be covering are the first two that you see on this list related to eggs, primary ovarian insufficiency and ovarian follicular genesis, and then the second two are related to problems with sperm. I'll be starting out giving you an overall introduction to primary ovarian insufficiency. So when I see patients with primary ovarian insufficiency, they can come to me in a number of different ways. For example, a woman may be 34 years old and go off the birth control pill that she's used for contraception and find out that she no longer has her menstrual cycles. And that the birth control pill does not cause the egg supply to deplete, but when a woman is on the birth control pill, she's having essentially artificial, regular menstrual cycles. And when she goes off the pill, she finds out that her problem with dropping egg supply has essentially been masked while she's been on the pill. You may also see a 17-year-old whose menses just stopped happening after having her first menstrual period at age 15. And then finally, there may be some women who have a very defined reason for a low egg supply, such as a need to take chemotherapy that is toxic to the ovary to treat a condition such as cancer. When you think about primary ovarian insufficiency, it's actually helpful to first consider what is ovarian reserve. And ovarian reserve generally is defined as the quantity and quality of oocytes as they relate to fertility potential. Quantity and quality are correlated, but it's important to also know that a young woman may have a low quantity of eggs and still have a good quality of eggs and be able to become pregnant as long as her ovary is still allowing the release of eggs. With increasing age, fertility is reduced not only because of quantity, but also because of drops in quality. And in particular, as a woman gets older, there's a greater chance that her egg will have the wrong number of chromosomes, as termed aneuploidy. What we're mainly able to assess clinically is really quantity. There are several different ways that we do a clinical assessment of ovarian reserve. And one of them that some of you may be familiar with is a blood test for follicle-stimulating hormone, or FSH, and estradiol that's done on the third day of the menstrual cycle. With low egg supply, the FSH level will rise. An ultrasound can be done for antral follicle count. So if you look at the picture of this ultrasound of the ovary, you'll see some small black circles contained within the ovary. Those are follicles, which are little sacs of fluid that contain an egg. And each month, a woman starts to grow many eggs. Only one is chosen to release, and all of the rest of them die off. And what happens is, as the egg supply drops, the antral follicle count drops. It's almost as if the woman's body knows that her egg supply is running low, and there are fewer eggs offered up into what's called the recruitable pool, or fewer eggs that are put up for possible selection to become the one that ovulates as a woman's egg supply drops. And then finally, we commonly use a blood test for anti-Müllerian hormone, or AMH. And as the egg supply drops, AMH drops. AMH is made by the cells lining the follicles that you can see on ultrasound. So with that background, you can think about what's the definition of primary ovarian insufficiency. And the terminology in this field has been a bit confusing. Primary ovarian insufficiency has classically been called premature ovarian failure, or POF. And then some of us also use the term premature ovarian insufficiency to emphasize the fact that this is occurring at a young age. So in general, POI is defined as depletion of the egg supply before the age of 40. And although we'll be focusing on the drop in fertility that's associated with POI today, there's I should at least briefly mention that there's a spectrum of other health consequences, such as hot flashes, mood disturbances, vaginal dryness, and bone loss that can accompany this drop in egg supply due to a drop in estrogen production. Most women are hit by this diagnosis by surprise. There's a spectrum of ovarian reserve. So as the egg quality begins to decline, sometimes the woman would have no idea about that because both her blood tests and her menstrual cycle will seem to be quite normal. Diminished ovarian reserve is a condition in which the egg supply is now able to be detected to be low based on a lower anti-Müllerian hormone is usually the first sign, and also sometimes by a rising FSH level. In these women, women will have regular menstrual cycles but have a drop in fertility associated with the lower egg supply. And finally, primary ovarian insufficiency in its most severe form, also called premature ovarian failure, occurs as the menstrual cycles now become irregular or even stop happening altogether. And you see the arrows on the far side of this table indicating that women don't necessarily move through these different stages of ovarian function in a very regular way, that sometimes the menstrual cycles may be absent for a while, and then there'll be a time period where the cycles will occur regularly for a few months, even though the egg supply is low, and then perhaps stop happening again altogether. We administered an online quiz to a number of university women in the Bay Area, and you can kind of think about how you would do on this quiz. So women are born with all the eggs they will ever have. Answer to that is it's true. Does smoking reduce egg supply? The answer is yes. Women can consider freezing eggs before they undergo cancer treatment. The answer is yes. Regular cycles occurring while a woman's on birth control pills are reassuring with respect to egg supply. No, and the answer is false. And most of the women who took this quiz actually got the answers to these right, but the next two were often missed. Diet and exercise will preserve egg supply. Unfortunately not. Even though these are good health habits in general, women really can't control their egg supply by those good health habits. And then finally, with the option that's so high-tech, like IVF, women will be able to conceive even if their egg supply is very low. Unfortunately, that's often not the case. What causes POI? About 80 to 90% of the time we don't know. There may be a problem with the X chromosome that's been detected, say, in research studies, but it's not in a clinically available test. Some women may be missing one of their two X chromosomes in some or all cells, and women who have this problem often will stop having menstrual cycles at quite a young age. Fragile X or FMR1 premutation is one of the most common causes of definable causes of low egg supply. And women who have this condition have a chance that they could bear a child having Fragile X syndrome, which is the most common cause of intellectual disability in the United States. chemotherapy or pelvic radiation, rarely autoimmune causes, and a number of other rare causes have been defined to cause POI. What should you do if you think that you may be at risk for POI? So first of all, be sure that there are no other more common causes for irregular menses, a number of them listed on this slide, and you can ask your physician to check for these things. To make the initial diagnosis of POI, we typically ask women to have a blood test for FSH and estradiol and anti-Müllerian hormone. And we typically, in our practice, also perform a pelvic ultrasound for antral follicle count. Once the diagnosis of POI is made, you should ask your physician to have a karyotype performed, particularly if you're under 30 or if you're not sure when your POI began because you were, say, on birth control pills, to have a Fragile X premutation checked, and also an adrenal antibody. Family building options for POI, one can be to attempt pregnancy as soon as possible if there's still some menstrual cycles occurring, but they're occurring irregularly. Women who are not in the position where they are ready to have a child now could consider fertility treatments, or fertility preservation, I should say, which I'll mention briefly. But this is only possible if the diagnosis is made very early, while there's still some ovarian function remaining. Oocyte or embryo donation, adoption, child-free living, and then an experimental treatment, in vitro activation, that Dr. Hsueh will be discussing. But a general principle is that fertility medicines really don't work to release eggs if POI is being diagnosed at an advanced stage. Can we stop the biological clock with cryopreservation? There's been a lot of discussion about this, and even in the media more recently. We have a number of ways that we can attempt cryopreservation. Traditionally, we've done this with the creation of embryos that are then frozen. But this, of course, requires that a male partner be involved, and is not really an option for many women. More commonly, women are considering to freeze eggs. It's also possible to freeze ovarian tissue or immature eggs. Freezing eggs is no longer considered experimental, but there are really very limited data that allow us to predict success rates for women electively freezing eggs, and no data really for women specifically with POI. More eggs frozen is better than, and there's really no guarantee. Freezing eggs is not actually guaranteeing that there'll be one of those eggs capable of turning into a baby. And ideally, we'd ask women to freeze 10 or 20 eggs, but when women are having the early stages of POI, they typically would only be able to freeze perhaps 1 to 2 or 3, maybe 5 eggs at most. And this doesn't really give them a good chance of being able to have a pregnancy in the future. So early diagnosis is really the key. We'd ask you to think of the menstrual cycle as a vital sign, just like pulse, respiration, or blood pressure. And if your cycles aren't regular, your body's trying to tell you something. We ask you to have an evaluation of ovarian reserve if you're experiencing this cycle irregularity, or if you're at risk for POI, such as if you have a family history of early menopause, if you've had to undergo or about to undergo cancer treatment, or if you've had surgery for severe endometriosis. And it's important to remember that if POI is diagnosed any stage other than the very, very earliest stages, egg freezing and other fertility treatments, unfortunately, are not viable options. One option that is considered a viable option is oocyte or egg donation. And if you look at the orange line on this graph, you can see what happens with age-related infertility. But women who are undergoing egg donation, which are the blue points on this graph, you can see that really into the mid and even late 40s and to age 50, the success rate or chance of having a baby really doesn't change if the egg is being donated by someone under the age, particularly under the age of 30. This is a very well-established and successful treatment for women with POI of any age. But it's acceptable to some and not all couples, and therefore we think it's really important that newer treatments be developed. And so Dr. Hsueh is going to be speaking about ovarian follicular genesis and in vitro activation.
Thank you, Val. As Val already indicated, I'm a basic scientist, and today I want to tell you a translational story, that is what we discover in the lab can be used for clinical treatment. As you all know, in the human male, you have millions of sperm, And even up to 70, 80 years of age, the sperm supply does not really go down. However, in the human female, we have a totally different situation. Every month, every menstrual cycle, during the mid-menstrual cycle, you have 1 egg release. So throughout life, you only have 400 of them. And then the millions of sperm have to find those mature eggs that comes out only during those 2 or 3 days of the month. So it's like a dating game. It's a very unbalanced. You have all the sperm chasing the mature egg, 1 mature egg. So this become a major issue. That is, how do we really take care of the ovarian function? And as you can see in this slide, that is, the left-hand side shows the regular cycling woman. In the female, actually, we also have a lot of immature eggs, but only 1 of them reach above the dashed line every month, and only 1 of them will release the mature egg. And actually, the diagram cannot even show all the small ones, all the immature ones, because at birth, there are 800,000 of these immature eggs. And every month, about 1,000 of them start to grow, and only 1 of them will make, after puberty, only 1 of them will make per month to the mature egg. And another very important thing is, on the bottom it says that age-dependent decline in follicle number and egg quality, as Val already mentioned. That is, the egg quality and the number really goes down, these immature eggs. So by 51 years of age, there won't be much egg left. And the simple way of determining whether someone is fertile or not is using this dashed line. That is, above the dashed line, we see the regular menstrual cycle. Then we say someone is likely to be fertile. And after 51 years of age, and you are reaching menopause, there's no more menstrual cycle. But I want to note, I want to point out that the important thing is the menstrual cycle is actually a reflection of endometrium or uterine activity, and that's secondary to the activity of the follicles. And only above the follicle, above the dashed line on the left-hand side, those big follicle, antrum follicle and preovulatory follicle, will produce enough estrogen and progesterone to give you a reflection of the menstrual cycle. On the other hand, there are still a lot of follicle, immature eggs down there, and in this case, we try to figure out in the laboratory how to activate this immature eggs, and we call them sleeping beauties. And if we can get these sleeping beauties to wake up, then we will be able to still treat some woman who has early menopause. Okay, so we have worked out a procedure called in vitro activation. In this case, we used the rodent model and took out the ovary and treat them with drugs for only 2 days. 2 days later, we grafted the ovary back to originally to the animal model, and then eventually we took human tissue and human immature egg and then treated with the same drug and then put back to some immune deficient mice and then show that those eggs will mature into mature egg. And so after we demonstrate that the in vitro activation is capable to wake up all the sleeping beauty, then we started on the left-hand lower side, treat infertile patients. And this was done with our clinical colleagues in Japan. And the patient we're dealing with average 37 years of age, and they already have 7 years of no menstrual cycle. So 1 ovary was taken out, and then they will cryopreserve. They will went through the freezing procedure, and then when the patient is ready for the second laparoscopic surgery, the ovary was taken out and treated with this IVA drugs, that is in vitro activation drugs, to wake up the sleeping beauty. And then the tissue were put back to a pouch that's made under the fallopian tube in the patient. We monitor the maturation of the follicle and then eventually obtain the mature eggs. And the mature eggs were then went through the same and very, very well established in vitro fertilization procedure using husband's sperm, and embryo can be generated, and embryo can then be transferred back. And as you can see, we have now two success. Now we have the first baby was born, and this picture shows Dr. Kawamura, who performed all this surgery, and then the second baby was born 2014. So in the we can now look at this IVA procedure in a different way now, because we show the initial success using this extreme patients. And you can see that on the left-hand side is the regular cycle I already showed, and in the right-hand extreme side is the primary ovarian insufficiency, the patient I just mentioned and Val also mentioned. So this procedure demonstrates one thing, that is, even you don't have menstrual cycle for up to 7 years, you still have those immature eggs that's available for activation using the IVA procedure. If some of this egg can be activated to grow into mature egg, then fertility is possible. Instead of using the egg donation, you can have your own egg and genetic children. So this procedure now is being expanded to the middle panel, that is, to middle-aged infertile women. A lot of patients do not respond to the present hormonal treatment, but they still have some follicles. So it is possible that the IVA procedure may help them. And to the left-hand side, the red color also indicated the cancer survivals. There are patients who were informed of the cancer, and if they have to go through immediate chemotherapy or radiation therapy, there's no time to obtain mature egg through the regular hormonal treatment procedure. Then freezing the ovary is one option, and followed by in vitro activation. So there are major advances in biomedical research and our improvement our lifestyle. So in our ancestors, 100 years ago, a woman lived up to 45 years of age, and they don't even have to worry about menopause because they don't reach 51. And now everybody lives to 85 years of age, and then you have good diet, you have good lifestyle and exercise, and everybody has the illusion that your egg will remain healthy if you are healthy. But unfortunately, the 51 year of menopause time, 51 years of age, that has not changed throughout the history. So the lower line emphasize the age-dependent decline in follicle number and egg quality. This is something that cannot be changed. The IVA procedure can give you more eggs, but we still cannot solve the problem of the quality decrease. So I think it's important that we understand the basic ovarian physiology, and the understanding of ovarian physiology allow us to make some improvement of infertility treatment. But on the other hand, the overall understanding of to have early decision on the childbearing age, as well as to freeze the mature egg. And actually some company like Google and Facebook are already offering this as service now for their employee. So this is something I think we need to allow to make more people aware of this. Egg quality goes down and egg quantity goes down by 51 years of age. Thank you.
Now, because of course it takes an egg and a sperm to make an embryo and a baby and a child, now Dr. Eisenberg is going to be helping us to better understand some of the clinical implications of spermatogenesis failure.
Thank you, Dr. Baker and Dr. Hsueh. That was terrific. So as Dr. Baker said, I'm going to shift the focus a little bit now to the male, and we'll talk about the clinical implications of spermatogenesis failure. And what I want to start with is just to emphasize that male factor infertility is actually relatively common. So when we see couples come into the clinic, what do we find? Well, about 50% of the time there is a female factor, but 30% of the time there's actually a male factor identified, and 20% of the time there's a combination. So in total, about 50% of the time there's male factor infertility. And obviously, one of the standards that we're going to do is look at a semen analysis. So this is a light microscope. You can see of some sperm with heads and tails swimming around. And so when we do this analysis, what do we find? Well, about 50% of the time, very reassuring, everything is normal. All the parameters are normal. But the other 50% of the time, we do find some problems. So we can see low motility, which is the movement, low counts, which is obviously low sperm numbers, low volume of the ejaculate, abnormal morphology or poor shape of the sperm. And about 10% of the time, we actually find no sperm, so-called azoospermia, and that's what we're going to focus on for the remainder of this talk. So azoospermia is actually fairly common in this country. So it actually affects about 1% of men. So we have about 150 million men here in the United States. So that means about 1.5 million men have no sperm in their ejaculate. And then if we focus more specifically on men that are trying to reproduce, reproductive age men, that's about 600,000 men that are affected. So it's likely that we all know somebody that are affected with this. So we'll take a step back, and I think before we talk about azoospermia, I think it's helpful just to review male genital anatomy. So sperm production begins in the testicles. From there, it then travels through the efferent ducts to a structure called the epididymis, and that's where the sperm matures. It then transports out of the scrotum through these thick muscular tubes called the vas deferens. It combines with fluid from something called the seminal vesicle to form the ejaculate in our urethra, and then it's expelled from the body. So when we talk about azoospermia, or no sperm in the ejaculate, what are the problems? Well, there's two kind of main classifications that we have. So there could be a blockage, and sperm simply can't get out, or there could be a production problem where we're not making enough. And it's very important for us to differentiate those. So when we look at obstruction, the obstruction can really be anywhere in the genital tract. Most commonly, we see it in the epididymis, we see it in the vas deferens, or even the prostate. And the causes are either congenital, and that means that we're born with them. And so there's some men that are born with defects or lack of certain parts of the genital tract. Or it could also be acquired, and that would be some surgeries can cause blockages, can have an infection leading to scarring, which could sometimes cause blockages. And the other thing then can happen is there could be a production problem. And so for that, I think it's helpful to look a little closer at the testicle. So we have a little cartoon view here. And what's important to know is the testicle is filled up with hundreds of these tubules called seminiferous tubules, and that's where sperm production begins. And sperm production begins in a very kind of ordered fashion. So we begin what's called the spermatogonia, which is a germ cell, and then through these set patterns of division and differentiation, we end up with sperm. And there can be problems with that. And again, we have congenital problems. Men are born with these problems for a variety of reasons, or there could be acquired problems. And one of the classic examples for this would be chemotherapy. So some of the therapies can actually really deplete germ cell numbers and really impact the testicle. So it's important when we're talking about treatment options, we want to figure out which of these are going on. And so the first thing we'll do for an evaluation is get a history. So we find out medical problems a man has had, surgeries he's had. And then we'll do some a focused physical examination. Obviously, you're going to focus on the genitalia. We want to make sure everything is where it's supposed to be. Everything has a normal feel, consistency, size. And then we're going to do some selective laboratory tests. So obviously, the semen analysis is going to be confirmed. And then we'll do some standard hormone tests. So if you remember, the testicle does two things. It makes sperm, but it also makes testosterone. And testosterone is very normal, or very necessary for normal sperm production. So we look at testosterone and some of the other hormones involved in that axis, again, to get a better sense of what's going on. And then we're also going to do some genetic studies as well. And we do the genetic studies for a few reasons. One is we want to find out what's going on. Along with that, we want to find out how treatable potentially it is. And then there's potentially also implications for the offspring. So we don't want to pass on any diseases if we can help it. And actually, technologies now allow us to be able to prevent that. So one of the first tests we do is what's called a karyotype, where we just count the number of chromosomes. So we all normally have 46 chromosomes. Sometimes men have an extra, or they're missing one. Sometimes big pieces of one chromosome can go to a different chromosome. So those can all have very important implications for sperm production. We also look at the Y chromosome. So if you remember from biology, women have two X chromosomes, men have an X and a Y chromosome. And on the Y chromosome, there's a lot of DNA that's very important for sperm production. Actually, Dr. Renee Reijo-Pera taught us that. And so we want to look specifically if those are going on, because that does have some very important implications in terms of treatment options. And then finally, we look at some specific gene deletions or mutations. And one of the classic examples for this is going to be cystic fibrosis. So unfortunately, men afflicted with cystic fibrosis often have blockages of the genital tract. And this is important to note because it helps us target our therapies and then again, be able to avoid transmission to offspring. So let's talk about treatments a little more. So again, if we have a blockage, what can we do? Well, hopefully we can try and reconstruct it. And so I have some images here of an example of that. So if there's a blockage in the vas deferens, we can try and remove that site of blockage, kind of bring the two vas deferens, ends of the vas deferens together, these very fine tubules. We're looking under about 20x magnification here. We're putting in very fine sutures. They're actually finer than hair. And we can approximate things together. And that actually works a good chunk of the time, probably over 90% of the time. But unfortunately, not every man is reconstructible. And so sometimes we can actually just go in and get sperm directly from the testicle or somewhere in the genital tract. So that's another option for us as well. But if there's not a blockage, are there things that we can do about production problems? Well, it turns out there are. So an example of this would be a varicocele. So the testicles are outside the body because they need to be a little cooler than the rest of the body, so that anything that warms them up can be a problem. So one thing that can potentially do that is what's called a varicocele, which are dilated veins in the scrotum. Now, about 15% of all men have them, but they're actually a little more common in infertile men. And the thought is that having these large veins can warm up the scrotum. So it turns out if we can fix these, if we can tie off these veins, we can actually improve production. So again, we're looking at the microscope, and I have some images here from the operating room. So what we're doing is isolating these individual veins, and then we're going to tie them off with silk sutures. Now, these veins are very small. That's why we need a microscope. They're probably about 1 to 5 millimeters. But when we do this, about 70% of the time, we actually see improvements in sperm production. So it's a very good option. But sometimes these are not going to be present, and we still have no sperm production. And so then in that case, we actually have to look inside the testicle to see if there is any sperm. So this is so-called testicular sperm extraction, or TESE, T-E-S-E. You may have heard that term. So this is kind of relying on a few principles. One is that even though there's no sperm in the ejaculate, there still actually may be sperm in the testicle. So there's kind of a threshold of production that needs to occur for us to actually see it in the ejaculate. So even if we don't see it, there could still be present. The other thing that's important to know is that testicular function is very heterogeneous. So looking at one area of the testicle doesn't tell us what's going on everywhere. So that's important because when we're looking in the testicle, we want to be very thorough and kind of very complete when we're looking at things so we can try and determine where sperm production is. And then finally, sperm production from the testicle is actually capable of fertilization. I think this is mistyped, but we actually learned this through a revolution known as intracytoplasmic sperm injection, or ICSI. And in my opinion, this is probably one of the greatest revolutions of medicine in the last quarter century. So what this allows us to do is take a single sperm and inject it directly into an egg. So instead of needing millions of sperm or thousands of sperm, really you just need a dozen sperm, or maybe even just one sperm to be able to have a baby. So it's really been a remarkable revolution in the treatment. So when we look inside the testicle, what are we looking for? Well, if we're looking at one of these tubules again, we're looking for sperm. And so this is what a normal seminiferous tubule in the testicle would look like. And basically, there's a lot of cells there, right? And so that's what's going on. It's a very kind of robust process, very cellular process. But in these cases where there's very limited sperm production, we'll see a very different pattern. So this is something called Sertoli cell only, sometimes called germ cell aplasia. And so what you have is these same tubules, but you can probably easily see they're very different. They're very acellular. So there's these supporting cells, but there's actually no germ cells, no sperm precursors. There's another pattern known as maturation arrest, where we have some early sperm cells, but they don't progress all the way through. And then there's something called hypospermatogenesis, where we get sperm, but in a very, very limited quantities. So it turns out that these have very different appearance in the testicle, and sometimes we can actually be able to see. So if we go back to our model of the testicle, you can imagine all these lines represent different seminiferous tubules. And these green boxes then represent active spermatogenesis. So when we go in and do a random biopsy, you can see it'd be pretty simple to actually miss these. So what we do, though, with the aid of a microscope, is you can actually interrogate each of these individual tubules and pick out ones that are more likely to house sperm. And these would be the ones that look more cellular, so they're a little plumper, sometimes they're a little darker. And we can actually have very successful outcomes. So this is a light microscope view, and you can maybe see a few sperm in this image. And that's really one of the greatest joys after these cases, telling the couple that we were able to find sperm. But on the flip side of the coin, one of the hardest things that I do is breaking the news to the couple that we didn't find any sperm. But I'm optimistic that investigators like Dr. Reijo-Pera will be able to find treatment options for these couples. So with that, I'll pass things along.
Well, thank you. It's a pleasure to be here with my colleagues. I'm going to talk to you about our work on stem cells as a potential source of cells to treat male infertility associated with the production of no sperm. To begin, I'd like to just cover briefly the formation of the human germ cell lineage. Germ cells are the cells that ultimately will give rise to sperm and eggs. And shown on the top here, we begin life as a fertilized egg. Egg and sperm come together to form what's called the zygote. The zygote is a single cell carrying the maternal and the paternal DNA. It goes on to divide to 2 cells, 4 cells, 8 cells, and then ultimately forms what's shown in the middle of this slide, which is a blastocyst that has an inner cell mass and a layer of cells that will attach the embryo to the uterus. Following the formation of the blastocyst, a process called gastrulation occurs. And during this process, a very small number of cells, perhaps fewer than 10 cells, are set aside to ultimately become the eggs and the sperm of the developing fetus. These cells are called primordial germ cells, and they will leave the body of the embryo, and they'll migrate out into what's called the extra-embryonic membranes. They stay there for 10 to 12 weeks, and they multiply to approximately 500,000 cells. At about 12 weeks of fetal age, these cells will migrate up the hindgut, up the midgut. They'll find the developing ovarian testes and invade the ovary or testes. Ultimately, they will differentiate to form eggs or sperm. Now, men that have azoospermia, as Dr. Eisenberg said, in many cases lack production of sperm. Early in my scientific career, we identified a region of the human Y chromosome that is called an azoospermia factor region. The region I identified was the AZFC region that's deleted in about 10% of azoospermic men. There are 2 other regions of the Y chromosome called the AZFB and AZFA regions, and these are all associated with azoospermia. In some men, there's what's called Sertoli cell-only syndrome, meaning that there's absolutely no sperm produced, and in others there's very few germ cells, and in some cases a few sperm that are produced. What we wanted to do was to begin to both understand the fundamentals of human spermatogenesis, but ultimately move to assisting infertile men with azoospermia, such as those that Dr. Eisenberg sees. And so what we did is shown in this slide. We take skin cells, shown in the upper left-hand corner of this slide, ordinary skin cells, and we treat them with 4 different genes and develop what are called derive what are called induced pluripotent stem cells, or iPS cells. iPS cells are very similar to the embryonic stem cells and are able to make all of the different cell types of our body. We've also shown that they can make the early germ cells that give rise ultimately to eggs and sperm in women and men. We took these cells, these induced pluripotent stem cells, that are carrying the genetic information of the infertile man from which they were derived. In some cases, these iPS cells are carrying an AZF-A, an AZF-B, or an AZF-C deletion, and in other cases, they're from normal fertile men. We take these cells and we can do what's called differentiation in vitro. We add some growth factors, and we form germ cells, these immature precursors to eggs and sperm, in a dish. We also did what's called xenotransplantation. We took the cells and we directly injected them into those spermatogenic or seminiferous tubules that Dr. Eisenberg alluded to in the last talk. We directly injected these cells into these seminiferous tubules because we thought perhaps the testes is devoted to forming sperm and might direct these cells to form sperm. Now note, when we put human cells in a mouse, mature sperm formation is not possible. We know that because of the distance between the two species, we'll get the earliest stages that are called spermatogonia at most. But yet this allows us to have a proof of principle that the spermatogenic tubules are able to direct the differentiation of induced pluripotent stem cells derived from skin from an infertile man to the germ cell lineage. Okay, so we enrolled 4 men in our study. One was called AZF1. He's a normal fertile man, and then a man with an AZF-A, B, and C deletion. We made stem cells from these men, and we showed that these are embryonic stem cell-like cells, induced pluripotent stem cells, by differentiating them in a dish and showing we could get heart cells, muscle cells, neurons, liver cells from these cells. And then we inject them under the skin of a mouse, and we show that indeed they are pluripotent, capable of contributing to many different cell types. We then differentiated these cells in a dish, and we asked the question, can men with AZF-A, B, and C deletions make the early precursor cells, the early cells that will give rise to eggs and sperm, in a dish? And what we found was that men carrying iPS cells derived from men carrying Y chromosome deletions were all capable of making the earliest cells. AZF-A men with this small deletion of the Y chromosome made the fewest germ cells, and they seem to have the most qualitative defects in germ cell development, with the fewest genes expressed that are specific to spermatogenesis. Nonetheless, all of the men carrying Y chromosome deletions their iPS cells have the potential to form germ cells. We then went on to use xenotransplantation to inject these cells into mouse seminiferous tubules, because we know that in mice, this procedure of mouse embryonic stem cells, or iPS cells, are differentiated in vitro and then injected into seminiferous tubules. We get mature sperm that are capable of making young mice. And so what we wanted to know is whether or not these iPS cells carrying genetic deletions of the Y chromosome or from fertile men might be able to make germ cells in a mouse environment. What we found is shown here. When we transplant patient-derived iPS cells into mouse testes, we see in the upper left-hand corner is some fetal germ cells that have been injected as a positive control. What we see is that we do indeed get some cellular activity, shown by this green areas of this slide, from all of the cell lines that we injected. When we look a little closer, We can actually identify human cells by staining for a protein called pneuma. And you can see here that there are pneuma-positive cells in our transplants. These pneuma-positive cells express what are called markers that are indicative of forming germ cells. So markers such as VASA. And we see that when men are carrying AZF C, B, or A deletions, all of them make some of these germ cells. Now, the men carrying Y chromosome deletions make fewer germ cells, but nonetheless, they make germ cells. We see also that those germ cells that are made in many of these men, they appear to be normal, especially in men carrying AZF-C deletions, the most common deletions. But in some men, such as those carrying AZF-A deletions, there appears to be a block even in the earliest stages of spermatogenesis or germ cell development with some of our diagnostic markers not being expressed. Now, one of the things, the jobs of the testes is to actually reprogram DNA to essentially contribute to the next generation. So one of the worries of any technology is that perhaps this reprogramming process does not occur correctly. And so we actually looked at what's called methylation, a marker of reprogramming, in the cells that we transplanted. And what we see is that to the best of our knowledge, the reprogramming process is actually occurring correctly. And so there are a couple of considerations that we're looking at this time. One is whether or not we should differentiate the cells first in a dish before transplantation. And when we do this, what we find is that there is no tumorigenesis and the cells completely enter the spermatogenic pathways. And so we think that differentiating cells briefly for 3 to 7 days is probably a way to eliminate some of the adverse consequences that could occur. And the most adverse of consequences is that cells that do not enter the germ cell lineage could go on to form primitive testicular tumors. And so with pre-differentiating in a dish, we hope to eliminate this consequence. Okay, so we have a summary and a model shown here, but I'll just mention briefly that we are able to differentiate germ cells in a dish from all of the men in our study, those that have normal fertility and those that are infertile. There are fewer germ cells made from infertile men carrying Y chromosome deletions, but nonetheless, all of the men are capable of making germ cells. When we extend our studies to xenotransplantation, we see that we are able to use the environment of the testes to promote germ cell differentiation, and we can eliminate adverse outcomes by pre-differentiating cells before transplantation. And so what do we think the clinical use is? Well, we're turning to Dr. Eisenberg for that primarily, but it is our hope that boys that might have received chemotherapy early in life and have no germ cell lineage, no spermatogenic activity, might someday be able to restore their fertility through some of the applications that we are working on. Thank you.
So you can see that there's a lot going on from a basic science perspective for both eggs and sperm. One of the things that we would like to think about, though, perhaps you could help us with a little bit, Dr. Eisenberg. I briefly spoke about some general health implications that might occur if women have premature loss of their eggs, things such as bone loss and hot flashes. Could you speak a little bit about what general health implications there might be with association with low sperm?
Yeah, that's a great question, and I do get that one quite a bit in the office. I think that we're learning a little bit more about that every day, and I think we do think that fertility is kind of a window into later health. So there have been studies that suggest that men with lower sperm counts may have higher incidence of developing some diseases down the road. Lower testosterone levels, which can lead to bone loss, is potentially one of them. We do worry about cancers, some cardiovascular disease, so I always tell patients when they come in to ask about this, I don't think we know exactly why this relationship exists, but I think the best thing to do is probably see your doctor every year for just a general health checkup. I think the things that are important are lifestyle, not smoking, checking your blood pressure, cholesterol, things like that, making sure your diet is good, things that we can kind of control as we continue to understand why this phenomenon exists.
So, Dr. Hsueh, could you speak a little bit about what the next steps are in research related to in vitro activation, and perhaps also give our viewers, our listeners, some idea of who would be the ideal candidate to consider in vitro activation?
Yes. So as we emphasized as I emphasized in the last slide, we're certainly expanding into middle-aged women and also the cancer survivors. So as you can see, the IVA procedure actually involved two important freezing steps, which is very interesting. That is, first, the ovary were taken out, and then eventually the small pieces were activated, and then the mature egg were taken out and fertilized, and the embryo were also frozen. So it's very important to know that among all the scientific advances which you mentioned in terms of the freezing procedure, the tissue can be frozen, and we have two babies to demonstrate that's the case. So it's very important that from a basic science viewpoint, we have two ovaries. And the data has been very clear. If you take away one ovary, your menopause time, the most, will advance by 1 year. So it does not really affect overall reproductive situation. But on the other hand, you already know, we discussed, that is, by 51 years of age, there's no egg left. Because the advance in the freezing procedure, once it's taken out, either as an egg, mature egg form, or tissue, everything is frozen. Egg quality does not go down anymore. And I think that's a very important consideration. And overall, I think after 35 years of age, people already begin to worry about the hormonal treatment become insufficient or inadequate. And therefore, after 35, between 35 and 40, it's time to have to begin to think about this freezing the egg, mature egg, or in some cases, if you have to take out the ovary, then take out as early as possible, because once it's frozen in the test tube, it's considered to be not going down. The quality will not go down anymore. So I think that's an important consideration, a knowledge that the general public should know.
Yeah, one of the other things that we encounter as we're counseling women who are considering this option is obviously it is a highly experimental treatment, although very, very promising. And one thing that has been shown, at least to date, is that if the treatment is performed closer to the time of the final menstrual period, so as women are going through the later stages of POI, if more years elapse between when that final menstrual period occurs and when the ovary is actually removed and frozen, that seems to be associated with a lower chance of being able to retrieve eggs. And so there's just a really importance of speaking with your doctor about your options as early as is practical for you. So Dr. Reijo-Pera, could you speak a little bit about what you see as sort of the next steps in the process of generating iPS cell lines for sperm, and perhaps also I know that you also have work with eggs and embryos where you see the field heading. Is this a potential option for eggs as well?
So where we see the field going as far as men and spermatogenesis is we'd like to carry out our studies next in a non-human primate. So we believe that our cell lines that we derive, these iPS lines, have been optimized at this time. We grow them for very little time in the dish, and we are able to develop karyotypically normal lines, and so we'd like to inject those from lines from fertile men and from those carrying ACF A, B, or C deletions, and from those that have previously had chemotherapy and essentially lost their spermatogenic activity. We're going to inject those into the seminiferous tubules of non-human primates. We expect from that to develop two measures. One is the safety measure. Is this a safe procedure? And the second is efficacy. Associated with the attempts to restore fertility to men, we've also been exploring in parallel options to make germ cells through transplantation to the ovary. And of course, the ultimate product of the egg and the sperm is the embryo. And so we have to be able to assess the safety of anything that we do ultimately to the offspring. There are a number of diagnostic tools that can be used to make sure that the embryo is karyotypically normal and carrying genetic information that has not been mutated. I think as I consider this field that in some ways it seems almost radical to try to use stem cells to restore spermatogenesis, but the testes appears to be devoted to that purpose, and so I think that there's a very strong likelihood that the cells that are made, the sperm that are made, will be completely normal, because that is the testes' job, and it does it very, very well in most cases. And so we're enthusiastic about moving forward and seeing if we can create a normal sperm through the use of the man's own spermatogenic system.
Thank you. And kind of along the same lines, maybe you could comment, Dr. Eisenberg, on a question that sometimes comes up. If a man has very, very low sperm and perhaps even needs like a testicular sperm extraction, will the children be healthy who are created with the use of that sperm?
Yeah, that's another great question. You know, I think the short answer is that we think they will be normal, and there's not going to be any health consequences. You know, associated with a lot of these technologies, there have been, you know, this has been done hundreds of thousands, if not millions of times overall, and there's lots of studies in the literature looking at this very question. So most studies say that everything is perfectly healthy. There's no increased risk. Maybe some say there's a slight risk, but I think it's important to know that when we look at, you know, any kind of problems in the offspring, there's always some baseline rate. So let's say that rate is maybe 3%. So with some of these technologies, the rate maybe goes up to 4%. So it goes up a little bit, but on the absolute scale, it's probably the same. So it's, you know, in some ways I compare it to buying a lottery ticket. Whether you buy one lottery ticket or two, you know, your risk goes up twice that you're going to win if you buy two tickets, but ultimately it's probably an unlikely event. It's probably not going to happen. So not quite talking about winning the lottery, but the overall absolute risk, I think, is very similar.
And I think that's a general principle that we feel really strongly about, that we're really not trying to just help couples to have a child, but the goal is to have a healthy child, and also for the woman and the man to maintain their health, and the woman to have a healthy pregnancy as well. So we're not just trying to do things because it's possible for them to be done, but with the real goal that the children created are healthy. Some of you might be interested in later being able to view this talk again. Particularly, you saw some of the slides had quite a bit of complexity, and you might like to see them again. The URL that you used to link on to this webinar today can be used again. And will be remaining active. In addition, if you'd like to pass on that URL to others, please do so, because we would be happy to have the word spread. And one of the biggest themes, particularly for women and also for men, but particularly for women, is to consider looking into these issues as early as is practical for you. So we thank you very, very much for attending today's webinar, and are glad that you were able to join us today. Thank you very much.